Okay, everyone. Good morning, good afternoon, good evening, depending on when you are watching this. Welcome back to Chapter 7. We are going to be finishing up this chapter. We had just completed learning about how cartilage growth occurs in our body and then how bone growth occurs in the whole ossification process during our embryological development. And so now we're going to move into and talk about how our bones grow lengthwise here. So just a quick review here, when we're talking about bone growth and bone remodeling, yes, both of these phenomena do occur during, our embryological development. And that's going to be around 8 to 12 weeks into the gestation period. So knowing this, right, we'll talk about here in a few moments how bone grows lengthwise. So that is our interstitial growth, and that occurs internally. Then we are going to discuss the diameter, right, and that is referred to as appositional growth. So when we're talking about bones growing in length, we're really going to be focusing on the epiphyseal plate. And in our epiphyseal plate, all right, we will learn in chapter 9 that is a joint. Right, a highly immobile joint. Okay, but we'll see in the epiphyseal plate our osteoblasts. Remember, the blasts are the cells that build bone, and they are going to produce the bone tissue, but on the diaphyseal side of our growth plate. We have two sides to our growth plate. We have the epiphyseal end or side, and that is going to be near the end of the bone, either distal or proximal. And then we have the diaphyseal side, and that's going to be the shaft towards the center of the bone. So the osteoblasts are going to be producing bone on the diaphyseal side. Meanwhile, the chondrocytes are going to be making, cartilage closer to the epiphyseal side. And eventually that cartilage will be turned into bone here. All right, and this whole process will then lengthen the bone because it pushes the cartilage out away from the center of the bone, away from the diaphysis there. So let's talk about the epiphyseal plate here a little bit. Okay, so epiphyseal plate is going to be pretty much active, throughout your childhood. As you get closer to, your 20s, we will see the growth rate slowing down. Right. As that occurs, though, we will see, an increase in the osteoblast activity. So the osteoblast will be laying down new bone matrix and new bone tissue. Right. We talked about how what happens to the cartilage, how that cartilage gets converted over into the bone tissue. Basically, the calcification occurs, destroying or degenerating the cartilage. And then our bone building cells, the osteoblasts, move in and they kind of remodel over that matrix, that old degenerated matrix, and they kind of model the bone over on that, and then we grow new bone there. So we'll see as you mature, the epiphyseal plate will start to get smaller and smaller. And then eventually, the interstitial growth will stop. We'll talk about certain factors that influence this. And then once all that interstitial growth stops, the epiphyseal plate will then fuse, and what we are left with, we call the epiphyseal line. And we've seen some of those in lab when we've been looking at some of our long bones. So let's talk about our interstitial growth here. Again, this is going to occur at the epiphyseal plates. We have 5 zones. So we're going to start off on the epiphyseal side and work towards the diaphysis here. So I'm going to do what I normally do. I'm going to go through each step one at a time, and then I'll show you a picture of each step. So let's start off with the zone of resting cartilage. Here we're going to see our chondrocytes, hanging out there in the matrix. And this type of tissue is going to resemble, matured hyaline cartilage. All right, so let's take a quick peek here. Here you can see our zone 1. So that's what we're seeing, our resting cartilage there. The chondrocytes are just going to be maintaining the cartilage matrix. not a lot of activities going on, hence the term resting. Then we get to zone 2 here. Then we start to turn on the juice. All right, the cells there undergo, all right, rapid division. And they start to resemble like a stack of coins. So these cells will align themselves in long column-like formations, right? And so there's so many of them, there's not going to be a lot of room there. So the lacuna, the space in which they reside, are going to be flattened down. But keep in mind that these columns will be parallel to the diaphysis here. So this isn't, and look at the name of this zone, proliferating cartilage, okay? So when we're having something proliferating, it's going to be dividing. So that's zone 2. And you can see we have these longitudinal columns, all those cells sitting on top of one another, all the lacuna, all right, are flattened down, and they're parallel with the diaphysis here. So our third zone is going to be the zone of hypertrophic cartilage. So we know the term hypertrophy. So in this situation, we're going to see this tissue undergo hypertrophy, which is going to be an increase in size. So the chondrocytes are no longer dividing here, but they're now growing up. They're getting bigger. Okay, so when they get bigger, they undergo hypertrophy. So we see that here in zone 3. You can see that those cells are no longer being smushed down, and the lacuna are no longer going to be smushed down, right? The cells are growing and enlarging, okay? And the walls of the lacuna become thinner and thinner. So again, these first 3 zones, we're predominantly dealing with cartilage. Now things are going to change up a little bit, because now we're going to move into our zone 4. And so that's the zone of calcified cartilage. And as soon as you hear that from what we've talked about previously, you should know, right, that with calcified cartilage, we are going to kill off those cells. And that's exactly what happens here. Okay. In this zone, we get calcium deposits, and that starts to harden the matrix there, the cartilage matrix. And in doing so, we kill off or destroy those chondrocytes. And so that matrix has now become hardened, which is good because we're starting to set the stage now for the final zone, right? That's the zone in which we are going to turn that cartilage matrix into bone. So this is zone 4. And so you can see in some of these areas here in zone 4, we're not even able to see any chondrocytes because they're dead. But that cartilage matrix now is calcified and is hardening, getting closer to, all right, the rigidity of bone. And then that leaves us with our final zone, our zone of ossification. Right now, we're going to start to break down those walls of the lacuna. And so we're going to get some capillary growth in there. You know what capillaries are going to bring? They're going to bring that blood supply in there for the ingredients, the nutrients that we need to make bone. And then, of course, our osteoprogenitor cells are going to move into the area, and they're going to do what they do best. They're going to, all right, differentiate into osteoblasts. And then those osteoblasts will lay down that osteoid, and we're going to start to now spray or secrete that osteoid over on top of, all right, that calcified cartilage matrix. And then our new bone matrix will be all over that. And then that new bone matrix will then ossify, harden, and that will give us our 5th zone here. And that's why we call it the zone of ossification, because we are now going to convert all of that tissue there into bone tissue. So that's pretty much everything at the epiphyseal plate. So really, in zones 2 and 3, this is where we're going to see a significant amount of growth. That's where we're going to see a lot of that elongation of our long bones there. So primarily our bone growth is going to be seen in the proliferating and the hypertrophic zones there. And keep in mind, all right, that is going to be pushing out away from the diaphysis towards each of the epiphyses there. So as you know, as you are growing, you know, from infancy to childhood to adolescence, right, the epiphyseal plate will be active. But as we get to the latter stages of adolescence, more towards that maturity there, right, that rate of that cartilage production slows down, and then it'll eventually cease when you have reached what we call skeletal maturity. That means the bones aren't getting longer anymore or really growing. And so those growth plates close down, fuse together, and form that epiphyseal line there. So this brings us to our first clinical view for this video, and that's forensic and I can't talk today, sorry, anthropology, right? And this is how, you know, when we talk about, there's that show, I know I've mentioned this before, that show that was on, I think Fox, called Bones, and they were looking at these forensic law enforcement officers and how they would solve these cases. And I could be wrong. I never actually seen an episode. So, but basically, you know, you hear stories that they find a skeleton somewhere in the woods or wherever, and they're able to figure out what the age is, what the sex is, and it's these little tools that they use to help determine, right, the sex and the age depending on what the skeletal remains are displaying. So what we see is, if we're looking, all right, at our long bones here, if we see, all right, an open region there between the epiphysis, all right, and the diaphysis, right, then we can estimate, okay, that is a younger person. And then obviously, if there's a complete union, okay, then we can say, okay, complete union there, all right, this person, at least we know, all right, that this person is not a child. Usually the size of the skeleton also is able to tell us that also. But we know that they're a little bit older and they're pretty much done with adolescence. So there's a couple other ways that we can figure out the age of the skeleton, looking at certain areas of fusion in the skull, depending on which sutures have fused together. So all that is very helpful when we're trying to determine the age of skeletal remains. So, okay, I mentioned we just got done with the interstitial bone growth, all right? That's the internal growth that lengthens the bone. How about appositional bone growth? This is going to be growth that occurs on the periphery, and we know what's on the periphery of our bones is the periosteum. So within the periosteum, we are going to see appositional bone growth, and that means this is how we're going to grow our bone in width, like a trunk of a tree getting bigger and bigger and bigger over a series of years. So what we're going to see here is we're going to see the osteoblast laying down that bone matrix. And it does it like a tree growing out every year, all right? But our bones don't do it on a calendar year, all right? We'll talk about the factors that are going to influence this, right? But our osteoblasts lay down the bone matrix, and it starts to make the bones wider. And as it is laying down that, our osteoclasts are busy, all right, on the inside of the bone in the medullary cavity. And so they're resorbing the old bone matrix. So then our medullary cavity will also grow in size. And we talked about that in the endochondral bone formation there in our last class. So if I zoom in here you can see we're looking at a nice femur bone. You can see here with the infant, we have our medullary cavity, right, with our beginning area of bone surrounded by the periosteum. So the periosteum is going to keep putting down bone matrix on the periphery here of the bone. And you can see here's that old bone matrix, and here's the new bone matrix on the periphery. So meanwhile, as the new bone matrix is being laid down, the osteoclasts on the inside are going to resorb that old bone matrix. And in doing so, you can see how the medullary cavity is going to be getting bigger and bigger, right, as the periphery of our bone gets wider and wider because the periosteum is creating that new bone matrix. And that's really it for appositional bone growth. Okay, so again, keep in mind it follows the same rules as we talked about with cartilage appositional growth. It occurs in the periphery. The cartilage uses the perichondrium, right, whereas our bone uses the periosteum. right, that leads us to our second clinical view, okay? Dwarfism. In this particular instance of dwarfism, this is the achondroplastic dwarfism. There's different types of dwarfism. You can have a pituitary dwarf, you can have a thyroid dwarf. This is an achondroplastic dwarfism. So this, of course, is seen, right, in folks that are having an issue when they are trying to convert that hyaline cartilage to bone, right? Yes, this is the most common type that you will see. So in most of these folks, you will see that their long bones, their limbs, arms, and legs have stopped growing prematurely, right? But most of the other bones in their body, all right, do not suffer from this condition here. So the other bones will continue to grow normally. So now by comparison, these folks will appear to have a large head. And the reason why is a lot of that is attributed to because their limbs are shorter. So that relation there, it just appears to be larger. And in some cases, it is slightly larger, right? But it looks to be even bigger because of the short limbs there. But what we'll see here, okay, is an issue with those chondrocytes, right, in the epiphyseal growth plate. Okay, one, right, we're not producing, all right, a lot of these chondrocytes, and at the same time, we know what happens after, all right, proliferation is enlargement, it is hypertrophy. So we are lacking in proliferation, and we're lacking in hypertrophy. And so as a result of that, that ossification, that endochondral ossification process, all right, has an issue with that conversion process. And so these folks, their long bones and their limbs will resultingly be short in stature. Okay, so we talked about bone growth. All right, now let's talk about bone remodeling. All right, because we just saw what happens, right, in our appositional growth there, right, as our osteoblasts are laying down the new bone matrix, the osteoclasts are resorbing the old bone matrix. So let's talk about this bone remodeling. And obviously that the primary cell is going to be the osteoclast in that bone resorption, but we'll talk about that in a moment here. All right, so this is what we're going to see all throughout your adult years. And so this occurs both on the inside of the bone and the outside of the bone. The outside is the periosteum. And don't forget about the end osteum. The end osteum is on that inner portion there of the bone that is surrounding the medullary cavity. So what we'll see here is, all right, during this bone remodeling process, and it varies. And we're going to talk about why that varies. This, and I know I keep saying this, but we're going to talk about what factors are going to influence, all right, the remodeling rate here. All right, a lot of it will do with weight bearing, and there's hormone involvement here. Okay, so we'll see, for example, in the femur, right down by your knee, it's going to be replaced every 4 to 6 months. Whereas the shaft of the femur, the diaphysis, might not undergo, all right, a complete bone remodeling over the course of your life. All right, so like I said, it varies, all right, from region to region or bone to bone, all right, and there's some factors that play a role in that. And we'll talk about some of those factors here. Interesting fact that 20% of your skeleton is replaced yearly. So you do have that turnover rate, which is important. So when we get into bone remodeling, right, we got to talk about the bones that make, excuse me, we got to talk about the cells that make the bones, the cells that maintain the bones, and the cells that are going to resorb the bone. So that's going to be our osteoblasts, the osteocytes, and the osteoclasts. So here we're going to get into the factors that influence bone remodeling. And our two factors are going to be hormones and mechanical stress. Hormones and mechanical stress. So let's start off with the easier one of the two, mechanical stress. And I've talked about, I made an allusion to this in a class previously, when I was talking about how up in the International Space Station, how they have treadmills up there in which they really require the astronauts to be on these treadmills. Now, of course, we know that there's zero gravity, so you kind of just float around in space. There's no weight bearing going on up there. So they literally have to stand on these treadmills with a big band that holds them down onto the treadmill. And so it doesn't make them weigh anything, but it does put mechanical stress on their skeleton, right? So in a way, it would be considered to be weight-bearing exercise in 0G, right? But not so much, okay? Because you are weightless, but the force of that band pressing them against the treadmill will mimic that weight-bearing movement there. So with mechanical stress, that's what we're going to see through weight-bearing movement, working out at the gym with weights, right? Walking, for example, exercise, all this is going to help with, all right, what we refer to as normal bone remodeling, And here's what happens, okay? So when you start to undergo some mechanical stress, right, maybe you're wearing a heavy backpack, you're gonna go backpacking, right, for 6 months, you're gonna hike the Appalachian Trail, you're putting the 60-pound pack on your back, right? So that's gonna affect, all right, your body weight. So the osteocytes in your bones are going to detect that increase in mechanical stress. And so it's then going to tell, all right, the osteoblasts, hey, we're bearing more weights, right? We need to lay down a little bit more bone, you know, to compensate for this, to make it stronger so our bones don't break. Okay, so what do osteoblasts do? They make the osteoid, the organic part of the bone matrix. And so you know what happens? We already know that process, what happens. So they make the bone, the osteoid, and then it'll undergo calcification, and now we'll have new bone tissue. All right, so one way to increase your bone mass is to undergo weight-bearing activities. And I'll talk about this when we get into osteoporosis, but this is one of the things that is highly recommended for folks, all right, to one, avoid osteoporosis is to increase weight-bearing activities when they're younger, right? But also with people that do have osteoporosis, we encourage them to go ahead and try to do more weight-bearing activities. Now, of course, we're not going to say, hey, go hike the Appalachian Trail, you know, for 6 months, but there's other ways to do that. Okay, so that's what happens with our increased bone mass. Now, of course, with our decreased amount of bone mass, we've removed that mechanical stress. Perfect example, being up there in space, right? That zero gravity environment is going to decrease that bone mass there. All right, so that's the first factor that's going to influence bone remodeling. All right, the other factor are hormones. All right, hormones are chemical messengers, all right, these molecules that are made by cells that are in tissues, usually glands, and they're going to be released into our bloodstream. And they're going to travel throughout your circulatory system looking for what we call target cells, right? That's what we're looking for. We're looking for target cells. And what they'll do is they'll bind onto what we call cellular receptors on those target cells. And so they're going to activate those target cells to do stuff. All right, well, our target cells in this situation are going to be these bone cells. So some of the target cells that we're going to be influenced are going to be chondrocytes, osteoblasts, and osteoclasts. So we're going to now talk about how these hormones, how these chemicals are going to influence those cells, right? Either to activate and do what they normally do, or to deactivate and stop them from doing what they do. Right? And of course, this is going to affect the composition of our bone. And if we're affecting the composition of our bone, we're going to be affecting its growth. Okay, so that's it for the hormones here. Let's talk about them. Growth hormone. Now, I am going to tell you, folks, you are going to get into this in much more detail in chapter 17, which is the endocrine system. So I'm going to just kind of give you some of the basics for some of these hormones here. All right, so growth hormone, also known as somatotropin. You should know that term also. You should also know that growth hormone is made, all right, in the anterior pituitary gland. The pituitary gland has two parts, the anterior pituitary and the posterior pituitary. Anterior pituitary gland is also known as the adenohypophysis. The posterior pituitary is also known as the neurohypophysis. So growth hormone, all right, is going to be released by the anterior pituitary into your bloodstream. It's going to travel throughout the body. And on one of its journeys, it's going to stop by the liver. And it's going to stimulate the liver to make its own hormone called insulin-like growth factor, or IGF. We call that somatomedin. And so both growth hormone and insulin-like growth factor are going to affect the growth of cartilage at the epiphyseal growth plate. So they're going to stimulate the growth of cartilage. And we know that process because we just talked about it. So we're going to cause the chondrocytes to divide, all right, fast, rapidly undergo that mitotic division. And then after they proliferate, then they're going to undergo hypertrophy. And then you'll start to see, all right, that whole growth-like process occurring that we just talked about. I'm not going to repeat that because we just reviewed that. So that's the effect of growth hormone. How about thyroid hormone? Thyroid hormone plays a lot of different roles in the body, but it does play a role in growth in your body. Remember, I was saying when we were talking about the different types of dwarfism, there is a thyroid dwarf, okay, and that's somebody whose thyroid, right, is not obviously working correctly. So with thyroid hormone, we need to talk about the thyroid gland. Now, most of the time, our thyroid hormone affects what we call the basal metabolic rate in most of the cells of the body. But since this is chapter 7 and we're talking about bone, we're going to see how it affects the basal metabolic rate of bone cells. And again, what does it do? As long as your thyroid hormone is in good levels and well regulated, okay, you're going to have normal activity at the epiphyseal growth plates. But if you are deficient in thyroid hormone, then that normal activity decreases. And that'll affect your growth at the epiphyseal plates. Okay, so normal levels, good levels of thyroid hormone, okay, things are going to be floating around or flowing pretty smoothly. It'll be good. Okay, but if we decrease that thyroid hormone, then we're going to run into some problems and we're going to see a decrease in growth at the epiphyseal plates. All right, so if we're going to talk about our sex hormones, we need to talk about puberty because that's when these hormones, all right, start to get produced in significantly large amounts. So our sex hormones are estrogen and testosterone. So that's why you see large amounts of growth spurts occurring during puberty, because these hormones have started to be produced by the body. And we'll talk about how it's going to affect the bone here in a second. Okay. So when we say large amounts, this is going to make large growth spurts occurring. So what we'll see is, all right, both of these hormones are going to stimulate, all right, an increase in cartilage growth. And it starts that process. Like I said, more chondrocyte division, more hypertrophy, all right, then we're going to see more calcification and more ossification. And so all of that, all right, is going to help the epiphyseal plate, all right, grow and the diaphysis grow longer and push those epiphyses away from one another. Okay, so that is for the sex hormones. Glucocorticoids. These hormones are produced in the adrenal glands, specifically the adrenal cortex. They are steroid hormones, right? Now, normally when we talk about glucocorticoids, we mainly are talking about how they affect your blood glucose levels. All right? They are what we refer to as an antagonist of insulin. So insulin is going to decrease blood glucose levels, whereas glucocorticoids are going to increase blood glucose levels. Now, sometimes folks have to take certain medications that are steroid or glucocorticoids. Okay, cortisol is a hormone, all right, that is produced naturally by your adrenal cortex. But sometimes, all right, we give people, All right, cortisone injections. And if we have to do it over a large period of time, this is very important, we can increase bone loss big time. And especially you'll see this, and we're seeing this in, I won't say in large degrees, but something we have to keep an eye out because there's been an increased rate of asthma in children, at least here in the United States. And so for those kids, when they're taking, if they're on steroids because their asthma is really bad, we have to be careful because it can impair the growth there at the epiphyseal growth plate in their long bones. All right, another hormone, okay, is serotonin. Now we'll talk about serotonin a little bit more when we get into chapter 12, all right, but it's also known as a neurotransmitter. Neurotransmitter is how, all right, our neurons can communicate with other neurons or other target cells in the body, right? So in this case, we have found that with serotonin, all right, our bones have receptors specific to serotonin. Right? And as long as your serotonin levels are good, no problems, it's okay, right? So bone growth undergoes a normal rate of turnover and remodeling. But if our serotonin levels get too high, right, what we'll see is those osteoprogenitor cells cannot convert into osteoblasts. And if they can't convert into osteoblasts, we cannot make our osteoid. And so that is going to affect our bone density. And what we'll see is those folks can have low bone density. That's why there's a certain classification of drugs called SSRIs, selective serotonin reuptake inhibitors, commonly used with people with depression, anxiety. And so what these SSRIs do is that they keep the serotonin, which acts as a neurotransmitter, all right, for those folks, it keeps that serotonin in circulation in the vicinity of the neurons and the target cells there. And folks that have depression, we usually have lower serotonin levels. But this drug helps to keep the serotonin available so things can function properly, so it helps to decrease in depression. But in certain cases, this is why you have to be careful, all right, about not prescribing this classification of drug to kids that are too young, right? Or you don't want it to affect their serotonin levels too much because you can inhibit, all right, their bone density. So you have to be careful with that. Okay, so those are how we influence bone remodeling, mechanical stress, and those hormones. So now let's talk about blood calcium levels. How do we regulate blood calcium levels? In case we're not sure where I'm going with this, all right, calcium is an important ingredient in making our bone. Okay, it has several functions. And in fact, here's a couple of the functions below. Okay, one, we need it to make bone, but also we need calcium for muscle contractions. We'll learn about that in chapter 10. And then we also need calcium to initiate the process of exocytosis of neurotransmitters from neurons specifically, right? We need calcium to help with heart contraction and for the nodal cells, what we call pacemaker cells. And then, of course, blood clotting. So these first two functions we're going to talk about later on this semester. All right. The other two you'll talk more about in 211. All right. So that's why you can see that it's pretty important that we have calcium. So that's why it is essential to regulate the amount of calcium that's in your blood. You want to have enough so there's enough calcium on hand to do these different functions here. So we have two hormones that are going to regulate our blood calcium. We have our calcitriol, that is vitamin You got it. Vitamin D. Okay. Calcitriol is vitamin D, and then parathyroid hormone, also known as PTH. So just a quick review here. Where does vitamin D come from? Well, the sun helps to give us vitamin D through our skin. So that ultraviolet radiation from the sun is going to strike the keratinocytes in your skin, and the keratinocytes are going to make, all right, this substance called cholecalciferol, and it's going to circulate into your blood throughout the body. And as it circulates throughout the body, it's going to make a stop in the liver. It stops off in the liver and gets converted into calcidiol. And so then it cycles around throughout the body. Eventually, that calcidiol is going to wind up in the kidneys. And once it gets to the kidneys, then it gets converted into calcitriol. That is our active form of vitamin D. And what is that going to do for us? Well, in conjunction with parathyroid hormone, PTH, okay, it's going to make even more calcitriol, which is good because calcitriol is going to help us absorb from our gut, specifically the small intestine, all right, calcium. So vitamin D has several functions, but here when we're talking about blood calcium regulation, vitamin D is going to absorb calcium from your small intestine back into the blood, so you don't get rid of it. And then with the help of parathyroid hormone, it will help to make even more calcitriol. All right, so keep in mind, when we see low levels of blood calcium, right, calcitriol is going to help increase the blood calcium levels by absorbing more calcium from your small intestine. So I love this picture here because they show, all right, the importance of a glass of milk in regards to your vitamin D levels. All right, now a lot of times milk is fortified with vitamin D, it's added to it, but the best source, all right, and it's free, the best source for vitamin D comes from the sun. All right, so roughly about anywhere from 30 to 45 minutes of exposure to the sun is going to produce enough vitamin D that you need for that day. Now, here's the thing, okay? That's with most of your body being uncovered. Okay, that means you have to be in a short sleeve shirt, all right, and shorts, and close to half of your body needs to be exposed to the sun. Around this time of year, okay, we're going to see lots of vitamin D deficiency because people are wearing, all right, heavier clothing, pants, long sleeve shirt or jacket, hat, whatnot, and very little of your skin is exposed. So you need to have a good amount of your skin exposed to the sun in order to synthesize enough vitamin D. So that's what we're seeing here. Okay, so here are the keratinocytes. Ultraviolet radiation is stimulating, all right, that production here of that cholecalciferol, which is going to get dumped into the blood. It's going to circulate, go to the liver, get converted into our calcidiol. Then that calcidiol is going to make its way to the kidney, which will be converted into the calcitriol. There's definitely going to be a question on that. All right, how does calcitriol, right, what organ makes calcitriol? So you need to know that what organ makes it, okay, and what it does. Okay, so parathyroid hormone, PTH. Okay, where is that coming from? Well, it comes from the parathyroid glands. Those are located on the posterior portion of your thyroid gland, hence the name parathyroid. Right, there's small little dots, and they can be anywhere from 4 to 6 little groupings there in the thyroid. So with parathyroid hormone and calcitriol, we're going to see, all right, for example, in the bone, both of these hormones will act synergistically with one another. What does that mean? all right, the actions of one help to boost the actions of another. So they are both going to increase the amount of calcium from the bone. So why are they doing that? Well, parathyroid hormone gets released when there are low blood levels of calcium, similar to what we saw with calcitriol. So one of the things that I said, or functions of the bone, is it's a storage site. Okay, it stores calcium and it stores phosphate. Okay, we know what phosphate's used for primarily, I mean, for several things, but one of the important things that we've discussed in this course is that phosphate is needed to make ATP. So in this situation, right, both of these hormones are going to stimulate the osteoclasts. Right, we know that those cells are the cells that are going to resorb and break down the bone. And so in that process of them resorbing and breaking down the bone, right, they release phosphate and calcium into the blood. So in the bone, PTH and calcitriol act synergistically with one another. Right? In our kidneys, we are going to see the kidneys excrete less calcium in the urine. Okay, and in doing so, right, excreting less calcium, we're going to keep more of that calcium in our bloodstream. So we are going to see an increase in calcium resorption. All right, then finally, in the small intestine, right, only, this is important, only vitamin D or calcitriol is going to increase absorption of calcium from the gut. Okay, so in bone, they both act synergistically with one another to increase osteoclast activity. And increasing osteoclast activity increases calcium release from the bone, increasing blood calcium levels. In the kidneys, right, we are going to see PTH and calcitriol stimulate the kidneys to get rid of less calcium. It's going to reabsorb more calcium and keep it so you're not excreting it through the urine. And then in our small intestine, only calcitriol is responsible for an increase in absorption of calcium from your gut. So that's what this picture here is showing you. All right, the effects of parathyroid hormone and calcitriol on our blood calcium levels. So here's our stimulus, all right, low blood calcium, which is then going to stimulate the parathyroid glands to secrete parathyroid hormone. And that parathyroid hormone gets dumped into your blood and it's going to circulate throughout. Now, in the blood, it's going to come across the kidneys and it's going to help to convert, right, calcidiol into more calcitriol. So we're going to make more calcitriol, more vitamin D. Hooray, good for us. Then we'll see in bone, then at our tissues here, okay, both PTH and calcitriol are going to stimulate or increase more osteoclasts to break down bone to release calcium into the blood. In the kidneys, we'll see again, all right, PTH not only helps to convert more calcidiol into calcitriol, but it will then work with that calcitriol to increase calcium reabsorption, meaning we are excreting less calcium. We're decreasing calcium excretion into the urine by increasing the resorption of calcium by the kidneys into our bloodstream. And finally, in the small intestine, only calcitriol is going to be effective here, and it increases the absorption of calcium from your gut. In doing all of these things, we now have moved our blood calcium levels up to the appropriate range. We've increased our blood calcium levels, thereby resuming and getting back into homeostasis. That is a negative feedback loop right there. All right, our third clinical view. Funny that about Rickets, because we had a guy in college who was very bow-legged. And his nickname was rickets, okay? But what is rickets? Rickets is when you are deficient in vitamin D. And if you are deficient in vitamin D, then you're going to have less calcium available, which means our calcification process is going to be deficient, which means that osteoid tissue that's being produced by the osteoblasts is not going to have that rigidity. So the reason why these folks have a bow-legged appearance is because those bones are weight-bearing bones. And if they're not as rigid, they'll bend. And so they'll have, instead of having relatively straight legs, this is the knee, okay, they'll have this. Here's the knee, here's the foot. And so they'll have this bow-legged appearance. So there's a couple other things. I mean, it's not just going to be skeletal disturbances, all right? But they'll have low blood calcium levels. We call that hypocalcemia. And they can, if it's bad enough, they can be affected with tetany, in which we'll get muscle cramping and muscle twitches. Depending on how bad, it can be sustained muscle twitches for a long period of time. Again, that's all due to that hypocalcemia or that low blood calcium. And there's a test for it, and I can't remember the name of it, but you can pretty much place your hand right behind the parotid gland, which is one of those salivary glands by your mandible, by the ramus of the mandible, just in front of the tragus or the pinna of your ear. And you can elicit, I can't remember the name of the test, and it's bothering me right now. And you can get a twitch or reaction or invoke some tetany, and that's usually a decent sign. I mean, the best way to tell if somebody is hypocalcemic is to just draw blood on them and measure the calcium levels in the blood. Right? We are seeing a larger amount in our urban children. All right, again, that has to do with poor diets. Okay, one of the issues that we're seeing a lot more with kids is inactivity and poor diets. We're starting to see the return or an increase in incident rates for certain diseases, all right, that we thought that we had a pretty good handle on, but we're seeing an increase in that now. All right, calcitonin, we're still talking about hormones. The first two hormones that we discussed had to do when you have low blood calcium levels. So what happens when you have high blood calcium levels? Okay, no problem. We've got calcitonin, which is going to be produced, all right, by some of the cells in your thyroid gland. Your thyroid gland doesn't just produce thyroid hormone, it's going to produce calcitonin. And what I think of calcitonin is this hormone puts calcium back into things. Because your blood calcium levels are high. So we have got to get those levels back down, undergoing that negative feedback loop there. So how are we going to do that? How are we going to get calcium back into our bone tissue? All right. Well, one is we can inhibit the osteoclasts. So if we inhibit the osteoclasts, they're no longer going to be breaking down the bone matrix. So there's going to be a cessation, a stoppage to calcium being released from the bones. And so we're going to see, all right, blood calcium levels, calcitonin levels increase usually when people are starting to exercise. Because why do we need calcium? Again, for muscle contractions. So you want to make sure you have enough, okay? But if you get too much, then that's going to be a problem. So then our calcitonin, all right, hormone will be released to help regulate that and decrease that. So what does calcitonin do? Well, it's going to go to the kidneys and it's going to stimulate the kidneys to get rid of calcium. So it's going to increase the loss of calcium in the urine. And so if you're peeing it out, it's going to decrease the levels of blood calcium overall. All right, so we're getting to the end of the chapter. And of course, now with that, at the ends of these chapters, I told you, we're going to talk about how the effects of aging are going to influence the certain systems, whatever we're talking about. So let's talk about what it does to bone. Okay, so there's two ways that it affects, that aging affects bone. One is that it's going to decrease the tensile strength of bone. All right, and part of that is, all right, remember, osteoblasts secrete the osteoid. And the osteoid is going to be the ground substance, and the protein fibers are going to be what is found in the osteoid. Well, like I said, aging slows everything down and it makes less of whatever that it is that you're producing. So the osteoblasts are going to produce less proteins, right? So that means less collagen, all right, and less proteoglycans. So we're going to see a decrease, all right, in the rate of protein synthesis by those cells, right? And then we're also going to see, all right, an increase in the organic material of our bone, because we're decreasing the organic amount of material because the osteoblasts have slowed down in their synthesis of making the osteoid and the proteins in the osteoid. And by, how do I want to say this? By relation to that, all right, the level of inorganic material increases. And because of that, all right, your bones now have too much inorganic material compared to the organic material. Remember what we said before earlier on in this chapter, you need to have the right ratio of organic material to inorganic material. So if you decrease the organic material, and as a consequence of that, the inorganic material has increased, now our bones are going to be too brittle, which makes them more likely to fracture, break. We'll also see, all right, for another effect of aging on the bone, right, we will see a loss of calcium and other materials to make the bone matrix there, phosphate, whatever, okay? And so we have a loss of calcium and those other materials to make the bone matrix. Now those bones become thinner because we have less ingredients, and therefore they become weaker. So we're going to talk about this term here, osteopenia. Osteopenia is like the beginning to osteoporosis. Doesn't necessarily mean if you're osteopenic that you're going to become osteoporotic, though. So we're going to see osteopenia, all right, in pretty much everybody. As we get older, you're eventually just going to have, all right, less bone density, less bone mass. Now, normally this occurs around our middle ages, 35 to 40. But it varies from person to person because, one, hormone levels are different from person to person, and activity levels are different from person to person. But overall, what we'll see is the osteoblasts, all right, they slow down, okay? They start to decline in their activities. All right, but here's the thing, the osteoclasts keep chugging along. No change for them. So you're laying down less bone matrix, but yet the resorption part of the bone, okay, the osteoclast, hasn't changed. So bone resorption is going on at the same levels as it has been before. And so we'll start to see, all right, large amounts of bone mass decrease. Unfortunately, we see this more in women than we do in men. A lot of that has to do with hormone levels. Right, so you'll see, especially in some of the weight-bearing bones of your axial spine, like the vertebrae, for example, we'll see quite a bit. I see it all the time in x-rays. When I'm taking x-rays of the spine for patients, I'll see a significant amount decrease there, which leads us into osteoporosis. Okay, now osteoporosis, and a lot of us are pretty familiar with this condition here, right? But what we'll see is we get such a reduced amount of bone mass, right, that it starts to compromise bone's normal function. What's one of the functions? Support, movement, okay? So we'll see, right, these functions start to become impaired. Again, unfortunately, we do see it more often in older women. And a big reason for that is going to be hormones. So in general, vitamin D decreases for whatever reasons. For your diet may be changing. You're not getting outside as much. As we get older, our growth hormone levels decrease significantly, right? And do our sex hormones, estrogen and testosterone. And all those play a big role in proper amounts of bone density. So if we start to reduce those hormones, then we're going to see, all right, a reduction in the bone density or the bone mass. So what are we seeing? Okay, for osteoporosis, yes, we see, right, decrease in bone mass. So those bones become weakened and more likely to break. So some of the things that we look for that are causative agents for osteoporosis is the older you are, okay, the more likely you are to have osteoporosis or get it, okay? What happens during menopause? Right? We stop producing large amounts of sex hormones in women. If you're a smoker, same thing. You see osteoporosis higher, all right, in Caucasians. Family history is a very big role for genetics, right? And if you are an inactive person, right, you're not putting a lot of mechanical stress on your skeleton, and you're taking away one of the factors that can heavily influence, right, bone remodeling. So folks with osteoporosis are at a high risk for fracture, predominantly at the hip, weight-bearing areas, okay? Vertebral column too, because that also is weight-bearing. Wrist also, if they fall and they try to put their hand out, they can break their wrist. So how do we stop it? All right, well, one, okay, we stop it with diet and exercise. Now here's the thing. This is important in our younger days. Think of it like going to the bank and starting a savings account. You just keep putting money in it every month, and over time you build up that savings account. Same thing with our bones. What we do now when we are younger, all right, will have an effect in our older days. So think of it like that. You're just going to keep depositing into your skeleton the proper nutrients, right, and the proper ingredients to make, right, good, strong bone. Now, for those of us that have osteoporosis, there are medical treatments that we can undergo. There are plenty of pharmaceuticals out there, right? And they are targeting at slowing the rate of bone loss, while at the same time trying to increase or stimulate new bone growth. We're seeing plenty of drugs out there. But I like to use the old tried and true method, good diet, and just being active, physical activity. I know, easier said than done. All right, getting here to the end here, let's talk about bone fracture and repair. What is a bone fracture? It's a break. And there's a couple different types. There's a chart in chapter 7 that has a whole bunch of different types of fractures. I only listed a few here, some of the more common ones. Stress fracture. Okay, this is a repetitive use injury through increased physical activity. See it a lot in runners. People that run a lot of long distances will see these in their feet quite often. All right, a pathological fracture. Right, this is when you see a fracture because the bone was weakened by some sort of pathological condition or disease. Like if you have bone cancer, osteosarcoma, right, which is a bone cancer, that area can be more susceptible to a fracture because that bone in that area is weakened. So when you break your bone, okay, you can have a simple or a compound fracture. Right? A simple fracture is when the bones break, they do not penetrate the skin. Less serious. Compound fracture is when the bones break, one or both ends do break or pierce the skin. That's a little bit more difficult, all right, or serious, because if it breaks the skin, then it's exposed to infection. So you have to be careful with that. So again, this chart here, 7.16, this figure has all these different types of fractures. Again, if you're interested, go ahead and take a look. There's a possibility that there might be one question on a test that it might ask you about one of these types of fractures here. So I'll let you take a peek at that. So let's finish up and talk about fractures and how they are repaired. All right, so like I always do, we'll do one step at a time and I'll show you a picture and then we'll move on to the next step. All right, so when we're looking at fractures, they can take a while depending on where the fracture is. If it's further away from your heart or closer to your heart, or how many bones are fractured or how serious, okay? But in general, simple fractures take about 2 to 3 months to heal. I'm talking about complete heal. Compound are going to take some longer time to do that. All right, so here are the steps. There's 4. So in step 1, okay, you fractured the bone and you have torn some blood vessels. And so what happens? Blood is going to infiltrate the area of the fracture, right? And we're going to see some clotting going on. So you're basically going to get a hematoma, which is going to be like our blood scab inside the bone here. So that's what we're seeing here, okay? We've fractured the bone, we've damaged the blood vessels in the periosteum and in some of the blood vessels that are within the bone tissue itself. And so blood fills that area of the fracture and we form what we call a fracture hematoma. Okay, so that's the first step. So the second step now, we are going to form what we call our soft callus or our fibrocartilaginous callus. So what we'll see is, okay, the connective tissue in that area that is forming within that hematoma is going to kind of start to form a cartilage scab. So the fibroblasts that come on hand start to produce collagen. And they're going to start to kind of pull things together, try to stabilize that area. The chondroblasts, all right, in that area are going to start to form our dense connective tissue. Again, we're going to form, all right, this kind of cartilage scab here in the area to, because you know what's going to happen. If you don't, all right, this will become really clear here in a moment. We get to the next 2 steps here. All right, we're going to lay down our cartilage scab here first in that area where the hematoma was. So you can see all of this now starts to be infiltrated, okay, by the fibroblasts, and they're spilling out collagen. The chondrocytes there in that area are going to be producing, all right, that cartilage kind of scab, right, to help stabilize this region. And so we call that area the fibrocartilaginous callus there, or nickname it, we call it the soft callus. All right, so after that now, guess what? We are now going to convert that soft callus into a bony or hard callus. So we are going to replace, right, that soft cartilage tissue with bone tissue from our osteoblasts. So the osteoblasts infiltrate the area, and so they are going to start to grow and form trabeculae. And we saw what trabeculae looked like from our from the trabecular bone. And so now we're going to replace the fibrocartilaginous callus with a bony callus. So that's what we see here. You can see now, all right, we've made up this trabecular-like bone. Looks like that spongy bone kind of. And we've replaced that cartilaginous tissue with our primitive woven bone type of tissue. Okay, so it's not the best, but it's going to still be better than what we had before. And then finally, all right, we start to remodel everything. Okay, this is when we kind of put the finishing touches on everything. The osteoclasts come on in the area and they start to get rid of any extra bony material that we don't need. all right? And we're just going to be making some fine tuning tweaks, and we come in and we start to lay down our compact bone. So we get rid of that woven or primary bone. Remember that immature kind of crappy made bone? Get rid of that. We put our compact bone down in there. And so you'll see, okay, here on the bone, you see there's a slight thickening there along the compact bone. No problem, because over time that gets remodeled also, and that'll go away. All right, but what we've done is we've laid down our new compact bone here and here. We've remodeled and got rid of the osteoclast, resorbed all of that primitive primary bone and that woven bone. And now we've got our new compact lamellar bone in place, and it looks great. So that's it for fractures, and that's it for chapter 7. I hope you folks enjoyed it. I enjoyed talking about it, and I'll see you in class. Everybody have a great day.